in this setting and also tend to correlate with mental retardation. Those patients that don't have seizures usually don't have significant mental retardation. The other thing that can be seen with Sturge-Weber is hemiparesis. So here is a scan where you can see some of these features. Here we see some cerebral atrophy here, and you can also see enlargement of the choroid plexus and some leptomeningeal enhancement. And then this is on the right here is a more dramatic example. This is the tram track calcification that you can see, and this is in an older patient. But that calcification is usually not visualized early on. As far as imaging, typically most physicians that care for patients with Sturge-Weber recommend screening for Sturge-Weber with an MRI scan for a variety of reasons. There's no radiation involved, and it's also going to be a more sensitive study that's going to pick up on these early findings. A CT scan may be very valuable in an older child that's developed that calcification, but it's usually not going to be as helpful in a 2-month-old infant. So that's why getting a CAT scan as quickly as possible would not be the best answer for that question. And as I'm sure you know, port wine stains do not fade away. As we mentioned, they're permanent lesions, so that's why that's incorrect. And fortunately, there are not any cardiac associations with Sturge-Weber syndrome or with facial port wine stains that I'm aware of. Ready for another case? Here's number 6. We have about 5 more cases, and then we have a potpourri of things that we're going to go through. All right, so this next patient is a 6-week-old female who presents with a rapidly growing bright red plaque on the left face. The lesion was a barely visible pink patch at the time of birth and has grown dramatically. The infant cannot open the left eye completely, and there is a small ulceration of the skin over the columella. What condition does this child have? So here's the child on the left, again right after birth, with a barely visible pink stain involving much of the left face. And this is the child that presents to you at 6 weeks of age. So does this child have a port wine stain or capillary malformation, a nevus flammeus, a venous malformation, an infantile hemangioma, or an arteriovenous malformation? Okay, so the vast majority of you recognize this correctly as an infantile hemangioma. A few of you thought this might be an arteriovenous malformation. We won't be talking a lot about arteriovenous malformations, but I will tell you that they are quite rare, and they don't generally change rapidly over a few-month period. They may grow very gradually and become worse over time, but not dramatic growth in the first few weeks of life like we would see with an infantile hemangioma. And then I had a couple questions over the break about nevus flammeus and nevus simplex, and I think I'll just go ahead and mention this right now. A nevus flammeus is a term that is used synonymously with capillary malformation or port wine stain. A nevus simplex refers to those common vascular stains that you'll see in your infants over the eyelids, over the glabellar area, sometimes over the nose or the upper lip, sometimes on the midline of the back. And when you have lots of those little stains in all those areas, we refer to that as nevus simplex complex. Okay, so back to this child. This child has an infantile hemangioma. And when you think about vascular lesions, you want to think about them as being either tumors or malformations. Tumors are lesions that show cellular hyperplasia, and the most common vascular tumor in a baby or a child is going to be an infantile hemangioma. There are other types of hemangiomas that are fully formed at birth that we call congenital hemangiomas, which I think would be beyond what you need to know for the pediatric boards. There are other rare vascular tumors. There's one called a tufted angioma and a caposiform hemangioendothelioma. And I haven't seen these appear in content specifications yet, but I think they might appear at some point. The main thing that you want to know about that is it's a rare vascular tumor that can appear in the neonatal period that is what can be associated with Kasabach-Merritt phenomena, or some people call it Kasabach-Merritt syndrome, and that is a very serious consumptive coagulopathy where you get platelet trapping. We do not see severe platelet trapping and Kasabach-Merritt syndrome in the setting of the infantile hemangioma. So that is something we have known for about 15 plus years now, but occasionally there's still some confusion with that. Typically, you're going to see growth when you have a tumor. Malformations are developmental abnormalities. They're formations of dysplastic vessels, and it can involve any type of blood vessel from capillaries to veins, lymphatics, or arteries, and it can involve combinations of different blood vessels. The main thing that you want to be familiar with is the capillary malformation. I don't think they would ask you about some of the less common types of vascular malformations. But again, you want to understand these things have a very different biologic behavior, so if you see a lesion that's changing dramatically in the first few weeks of life, you're dealing with a vascular tumor, and the most likely thing is going to be an infantile hemangioma, where if you have a very stable lesion, then it's going to most likely be a vascular malformation. Okay. So as that little baby demonstrated, infantile hemangiomas have very significant growth or proliferation in the first few months of life, particularly in those first 6 months of life. The lesions then stabilize and then very gradually involute over time. So this is the baby that we saw, and this is pretty dramatic, but that's the type of growth you can see that was at birth and 6 weeks of life. So there's no type of malformation that's going to change dramatically like that in the first few weeks. So the next question is, this infant is at risk for which of the following associations or complications? A, Sturge-Weber syndrome, B, glaucoma, C, Klippel-Trenaunay syndrome, D, Faces syndrome, or E, vascular malformation of the leptomeninges. Okay, so the correct answer is D, which is Faces syndrome, and we'll talk a little bit about what that is. E, some of you guys put vascular malformation of the leptomeninges. So that would be what we would be worried about if this were a capillary malformation and this child had Sturge-Weber syndrome, okay? So we're thinking Faces syndrome in this baby because it's an infantile hemangioma. So segmental infantile hemangioma, you're worrying about Faces syndrome. Segmental capillary malformation of the upper face, you're worried about Sturge-Weber syndrome, where you have a vascular malformation of the leptomeninges as well as of the skin. Okay. All right, so let's talk a little bit more about hemangiomas of infancy. These are the most common tumor of infancy. About half of the time they're present at birth. The remainder appear by 1 to 2 months of age. And the overall incidence is believed to be somewhere about 5 to 10%, with hemangiomas being more common in females as well as premature infants. They're also more common in Caucasian babies. We can divide or subtype hemangiomas by the level of skin that they involve, and either define them as being superficial, which is the most common type. More than half of hemangiomas are superficial, involving the upper or papillary dermis. Deep hemangiomas are the least common type, and those involve the deeper reticular dermis as well as potentially the subcutaneous fat. And then there are a subset, about 1/3 of hemangiomas may have both a superficial and a deep component, and we refer to those lesions as either being mixed or combined. So here are a few examples. Here are 2 examples of superficial hemangiomas. These are the most easy to recognize. They are usually bright red in color in the first few months of life. They can be papules or plaques depending on the size, and again, they're involving the upper layers of skin. These 2 patients have examples of mixed or combined hemangiomas, where you can see there is a superficial component on the surface of the skin, but these patients also have an underlying deeper component. And then finally, the least common and often the most difficult to recognize are the deep hemangiomas. These can be more difficult to recognize because they can be skin colored, they can have a blue or violaceous hue to them, and it's really the clinical behavior that's the most helpful clue. Sometimes you will have warmth that will suggest that they're vascular lesions as well. But the deep hemangiomas, sometimes it's more difficult to make a clinical diagnosis, and you may have to support your clinical diagnosis with some sort of radiologic imaging, most commonly an ultrasound. Now, more recently, in the last 5 to 10 years or so, clinicians that see a lot of hemangiomas have started to define infantile hemangiomas as either being focal in distribution or segmental. And here are a couple examples. The child on the left has a focal, or sometimes referred to as localized hemangioma. And the definition of these lesions is still being worked out somewhat, but I think of focal lesions as being round lesions, round or oval. They seem to be arising from a single point and growing outward from that point. They're usually very symmetrical, and they don't seem to be conforming to any specific anatomic unit on the body. That's in contrast to segmental lesions, which often will have more of a patch or plaque type distribution and often seem to be pertaining to a specific anatomic unit on the body. They aren't round or oval. They aren't appearing to arise from a single point. So we can see that here in this patient. There seems to be a fairly sharp midline cutoff here, and it's really involving this upper portion of the face as well as this lip involvement, and it really involves the entire lower lip. So that would be a good example of a segmental hemangioma. Here are 3 more examples, again, fairly similar lesions, round to oval lesions, symmetrical, arising from a single point, not really pertaining to any specific anatomic unit on the body. Whereas segmental hemangiomas are plaque-like, often can be larger in size, and do tend to be conforming to certain anatomic units. Here are some more segmental hemangiomas, and hopefully you're getting kind of the flavor of this distinction. So why is that important? Well, what has been observed over the last decade is that segmental hemangiomas are much more likely to have significant complications and to warrant more aggressive monitoring and therapy. They're more likely to develop ulceration. They're more likely to be associated with underlying developmental abnormalities, and again, more likely to need treatment. So what are some of these underlying structural abnormalities that you want to be thinking about? Well, it really depends on where the lesion is located. If you see an infantile hemangioma involving the lower face or the beard area, one thing you want to think about is whether that patient could have an airway hemangioma. That's the most likely location to have an airway hemangioma, is when you have a skin hemangioma that involves the lower face, particularly if you have a bilateral lesion. The other thing you want to think about with the large facial hemangiomas is the face syndrome, which we'll talk about in just a minute. When you have lumbosacral extensive hemangiomas in the lumbosacral region, you want to think about the acronyms sacral syndrome, pelvis syndrome, and lumbar syndrome. Now, you don't need to memorize what all those acronyms mean. What you want to keep in mind is that if you see a segmental hemangioma in the lumbosacral region, you want to think about the possibility of that child having underlying spinal cord abnormalities or genitourinary abnormalities. So this child in the picture has a beard hemangioma. It's a segmental hemangioma, and this child developed significant ulceration, lost a part of the ear, and has a little ulceration on the lip as well. This child presented at a few weeks of age and didn't have any obvious symptoms of airway hemangioma, but we referred to ENT. They could see some vascular discoloration of the airway, but returned about a week later with respiratory distress. So if you think about it, the hemangioma is growing rapidly. That early period where the hemangiomas are proliferating is when you want to follow these kids carefully, because that's when they're likely to present with the airway symptoms. If a kid comes to your office as a year of age and has a beard hemangioma, has never had any problem, that child is not going to develop an airway issue. So this child happened to have both face syndrome and an airway hemangioma. So what do we tell parents? How long will the hemangioma last? When is it going to go away? Well, Probably most of them will go away by 9 to 10 years of age, more than 90%. However, a significant minority of those patients may have significant residual changes. They might have some persistent vascularity of the skin. If it was a large lesion that grew rapidly, they may be left with some redundant or sagging skin. If there was ulceration, there may be a residual scar there. Sometimes we see atrophy. So the lesions do go away, but you want to think about what kind of aftermath they might leave when you're considering whether to treat. So here are a couple examples. We can see the child on the left has some central involution. It's fading. It's flattening a little bit. This child will probably be left with some significant tissue textural changes. This child on the right, however, has had a really nice outcome and has just a little bit of vascularity left on the forehead, which you can see here. And that would be a patient that you could also consider doing pulse dye laser on. This child is an example of a deep infantile hemangioma of the parotid area. This child could have had airway involvement but did not. This child was from several years ago and was treated with systemic steroids and did very, very well with a combination of time and steroids. You can barely see where the lesion was. So some other things you want to think about when you're deciding whether to refer a patient with a hemangioma or wondering whether this child might need treatment. There are high-risk areas. We worry about the periorbital area because of the potential for ocular complications. We've already touched on large facial hemangiomas. We talked about the beard area. The nose, lip, and the ear areas are pretty high risk for leaving significant cosmetic deformities. And whenever you have something in the central face, you want to think about what cosmetic impact that may have, because that's where you look at people when you're making eye contact. The lumbosacral area we touched on briefly. The perineal area, the main problem in the diaper area, the perineal area, is that there's a very high risk for developing ulceration in that location. And then we'll talk very briefly about this, but when you have patients that have multiple hemangiomas on the skin or multifocal hemangiomas, then you want to think about the possibility of underlying visceral hemangiomas, most commonly involving the liver. So we'll talk briefly about periorbital hemangiomas. Both of these children here have infantile hemangiomas. The child on the left here had a segmental lesion that had retroorbital involvement and significant ocular complications that were not visible but appreciated on MRI imaging. The child on the right had a very subtle telangiectatic patch, which we will sometimes see where they don't necessarily grow rapidly, but they have this very lacy thread-like telangiectasia here. This child actually had retroocular, retroorbital complications as well due to the hemangioma there, but also had face syndrome. And that child, you can see, also has hemangioma here and had developed ulceration. So the things we worry about with periorbital hemangiomas, we worry about amblyopia, refractive errors, and particularly astigmatism. Occasionally, if they're on the lid, they can cause significant ptosis, and so we worry about it blocking the ocular field, and rarely they can cause blindness. But we want to get our patients evaluated by ophthalmology as soon as we can and make sure that they're followed very closely during those first few months of life when the hemangioma is likely to be growing rapidly. So back to the kiddo that was the question we asked a couple minutes ago. This child had face syndrome, clearly at risk for ocular complications, developed ulceration there. Okay, so with the large segmental hemangiomas, we worry about face syndrome. And both of these babies have segmental hemangiomas. This child on the right has one of those flat telangiectatic hemangiomas, has ulceration in the ear. She had Dandy-Walker malformation, had coarctation of the aorta, and had all of the classic features of face syndrome. Whereas this little boy on the right definitely has a segmental hemangioma, but was lucky enough not to have any other malformations associated with that would suggest face syndrome. So what is face syndrome? The acronym stands for, the P stands for posterior fossa malformation, so cerebellar abnormalities, Dandy-Walker type abnormalities. The H is the hemangioma, and this condition is seen primarily in children who have segmental hemangiomas involving the face and neck. The A is the most common anomaly that you'll see in this condition. The A stands for arterial anomalies or arteriopathy, however you find that easier to remember. And these are intracerebral arteries.
The C stands for cardiac anomalies, most commonly coarctation of the aorta. The E is for eye abnormalities, and the S is the least common, and most people refer to this as face syndrome versus faces syndrome, although you'll see it both ways. The S stands for sternal defects. So a patient doesn't have to have all of those things, but must have the hemangioma plus one of these other criteria, and most commonly you're going to see the facial hemangioma, and then you'll see these arterial anomalies if you do imaging, neuroimaging with MRI and MR angiography. So this child has face syndrome. This is when she's a few weeks old. This is a bit later, and this is a little bit older patient too that has had treatment with steroids as well as pulsed dye laser. And this is the same child. She did have the posterior fossa abnormality and eventually required a ventriculoperitoneal shunt, which you can see in the photo on the right. This is another patient with the segmental facial hemangioma. This child does have face syndrome as well, and this image demonstrates the abnormality in the vessel, the arterial vessel here on the right side. You can see as compared to the normal side, it's very dilated and tortuous, and that's one of the types of vessel abnormalities you can see. You can also see hypoplasia or even missing arterial vessels, internal carotid, external carotid, and these patients, again, can have a variety of different arterial anomalies. But I think the most important thing to remember is segmental facial hemangiomas. You want to think about the possibility of face syndrome. There have been some recent articles in the pediatrics literature. This condition is probably far, far more common than Sturge-Weber syndrome, and you probably will have patients or have patients that do have this. The only other point I want to make about that is the significance of these intracerebral arterial anomalies is really variable. Some patients are completely asymptomatic, doing very well developmentally, no issues at all, whereas some of the more severe abnormalities or high-risk arterial anomalies like significant hypoplasia or stricture, there are reports of stroke in the infancy period and even sometimes prior to birth. So it's something you want to be familiar with. We talked a little bit already about beard hemangiomas and how this can be a problem, particularly in the first few months of life. So if you have a baby that has a large segmental hemangioma of the lower face or beard region, you certainly want to be screening regularly for any signs or symptoms of airway involvement, such as noisy breathing, stridor, cough, hoarseness, or cyanosis. Obviously, that would be extreme. But something you want to have a pretty low threshold. If you have any concerns at all, you really want to get your ENT colleagues involved and have the child scoped to see what you're dealing with, because that may dramatically affect the way you treat that child. There was one study back in 1997 that showed that if a child had a hemangioma that involved both sides of the beard area, there was a 60% risk of having airway involvement. So it's not a trivial risk. It's a significant thing to be watching for. And this is a child, this is one of the first kiddos that I followed with a significant airway hemangioma. You can see that she has a segmental lesion. This is a mixed lesion with a superficial as well as a deep component. You can see there's involvement of the tongue and the lip. This is the same child here on the side, and she had a symptomatic airway hemangioma as well. And we've talked very briefly, but when you have lumbosacral hemangiomas, again, you want to think about underlying spinal cord abnormalities as well as underlying genitourinary abnormalities. And I think you want to be particularly suspicious if you see an infantile hemangioma in this distribution and you see any other additional markers of spinal dysraphism, such as sacral dimples, skin tags, deviated intergluteal cleft, and I'll show you a couple examples. The most common thing, though, to see associated with this is going to be the tethered spinal cord. So here are two children that did have underlying spinal cord abnormalities. The child here on the left, you can see, has a large hemangioma that overlies the midline. You can see this child also has a very high-lying, deep sacral dimple. So that's the child that you want to assume has a problem until proven otherwise, and you want to get an MRI scan on that child. This child on the right has a hemangioma there. You can appreciate some underlying fullness, which could be the hemangioma, or it could be an underlying lipoma or other growth. And then you can see that this is a very deviated intergluteal cleft. So again, another sign that would make you want to look further. But there is a very, very high risk of underlying spinal cord abnormalities, even in babies that have an isolated hemangioma. So again, another high-risk lesion. So I think we've made this take-home point already. Higher risk of spinal dysraphism and renal anomalies. I will frequently get an ultrasound of the kidneys to look for any underlying abnormalities. Ultrasounds can be useful screening tools, but are not considered the gold standard if you have a high level of concern. But I think are a good starting point, especially if you don't want to give sedation in a very young infant. You could start with an ultrasound at a couple months of age and then follow that up with an MRI scan. We talked briefly about ulceration. This is a complication. This is the most common complication of hemangiomas. It occurs mainly in large, rapidly growing lesions. There are some high-risk sites. The perineal area is probably the #1 site. We also see it commonly on the lips and fairly frequently on the scalp, but they can occur anywhere. You want to treat ulcerations early because there's significant morbidity associated with them. #1, they hurt like heck, and these babies are miserable, and their parents are miserable, but also there's a fairly high risk of infection, bleeding, and scarring with ulceration. And this is just a photograph. This is actually a healed ulceration, but you can see the scarring in this child and in this extensive segmental hemangioma of the perineal area. Here's another example. This is a larger focal lesion with a large ulceration. Fortunately, this child healed up quite nicely, but again, the diaper area you want to watch very closely for any signs of skin breakdown. And then this is a very, very rare complication. This child has an enormous segmental hemangioma involving the chest and arm and the upper back. You can see this is at about 8 weeks of age on the left, and this is the same child at 6 months of age, where you can see that the deep component has gotten much thicker, and this lesion has become much more voluminous. This huge lesion was in a premature baby, and this child did develop high-output congestive heart failure, but I just want to emphasize that's an extremely rare complication in the setting of infantile hemangiomas. And then I mentioned earlier that when you see children that have multiple small hemangiomas, and we usually define that as being more than 5, that tends to be the high-risk number. There is an increased risk of having internal hemangiomas. So in my younger infants that I'm seeing, if I'm seeing them in the first few months of life, I will usually get an abdominal ultrasound to screen for liver hemangiomas. The liver is the most frequently involved organ. And the risk, there are some nice articles in the literature in the last few years, but when you have more than 5 cutaneous hemangiomas, the risk is somewhere probably between 15 and 20% of having hepatic hemangiomas. The good news is, though, that most of these babies that have hepatic hemangiomas have a very good clinical course, and the lesions in the liver go away, similar to the ones on the skin. Now, there are exceptions to that, and there are types of hepatic hemangiomas that can be very serious and can be associated with high-output congestive heart failure, liver failure, and hypothyroidism. But again, that's the exception. Most of these kids do very nicely. So in summary on hemangiomas, when you're approaching a patient with a hemangioma, fortunately, many of these children will do great. The lesions will involute spontaneously. They may be somewhat of a cosmetic concern, especially if they're on the face. But when you're thinking about whether to refer and or treat a patient, you want to think, is this hemangioma going to threaten the vision, the airway? Is there a risk of CHF? You want to look at the child and think, what's the risk of a cosmetic deformity, permanent scarring? How is this going to affect the child the rest of their life? With the large facial hemangiomas, we've already talked about how you want to think about face syndrome and consider working up the patient for that. And the literature suggests if the lesion is more than 20 square centimeters, you want to think about doing a workup for face syndrome. We talked about lumbosacral, we talked about ulceration and multifocal. So those are reasons I would personally recommend referral in patients that may be at greater need for treatment. And this is essentially saying the same thing. I mean, obviously you're going to treat the patient if they have significant ulceration, if they have a visual issue or an airway issue. I think what becomes more difficult is when is the cosmetic concern enough that they warrant a systemic agent such as corticosteroids or propranolol, which has really kind of taken over hemangioma treatment in the last few years. Certainly if you have a medical problem, you're going to be more aggressive in treating. And then as far as treatment, again, many patients can be observed successfully. We use a lot of photographs to demonstrate progress to parents, a lot of reassurance. For 40-plus years, corticosteroids, primarily oral steroids, were the first-line therapy for infantile hemangiomas. Since 2008, propranolol use has taken off dramatically, and I'd say that is the first-line agent for most clinicians, and I could see something like that potentially appearing on the boards, although it has not, to my knowledge, as of yet. Laser therapy, we talked about how you could use it for port wine stains, but it can also be useful in two particular settings with hemangiomas. One is with ulceration. There's some evidence to suggest it's helpful for treating ulceration, and the other is for older children who have residual vascularity of the skin where the redness hasn't faded away completely. And then finally, surgical excision can be helpful, particularly for those children that have very pedunculated lesions and those that are left with a lot of redundant skin. Okay, so let's go on to case 7. This is a 6-year-old male who presents to clinic with an erythematous crusty scaly plaque of the posterior scalp that's been there for a few weeks. Upon further inspection, there are several additional pustules scattered throughout the scalp, as well as enlarged occipital lymph nodes. What is your differential diagnosis? So here we see the child here. We see this crusted plaque here in the scalp. This is a closer view. You look closely, you can see a few other spots there. So this is likely going to be your differential diagnosis. Is this tinea capitis? Is this a bad case of seborrhea? Could the patient have alopecia areata, psoriasis, atopic dermatitis? Is this a bacterial folliculitis, an MRSA infection? What can it be? So what studies might you do to arrive at a firm clinical diagnosis? Are you going to do a bacterial culture from the pustule? Are you going to do a skin biopsy from the affected scalp? A fungal culture from the scalp? A potassium hydroxide scraping from the scalp, or some other workup? Okay. I didn't mean to trick anyone here. I think the best answer is a fungal culture of the scalp. So in this patient, we were worried about tinea capitis. You can, if you're really good at doing potassium hydroxide stains, you can do them, and you can read them in your office. I will say that the scalp is probably the hardest area to do them. And the downside of doing a potassium hydroxide staining is that you have to let it sit for a long time for that hair to dissolve. So I think the culture is definitely the best way to get it. It's going to be more accurate, and you're also going to be able to identify the fungal pathogen, whether it's trichophyton, whether it's microsporum, which may help you in your treatment. So again, KOH, most people aren't that great at doing KOHs. I'm not that great with the scalp KOH preps, and really the fungal culture is going to be your gold standard for making a diagnosis of tinea capitis. So again, if you're really competent at them, I think that would be fine, but that's a hard thing to do in the office setting. Tinea capitis is a very common infection in children. It affects 3 to 8% of the pediatric population in the United States. It's an infection of the hair follicles by a group of fungal organisms called dermatophytes. Again, ages 3 to 7 are probably the most commonly affected kiddos. And for reasons that are not well understood, this condition is more prevalent in African American children. The most common dermatophytes organisms to cause tinea capitis are Trichophyton tonsurans, and followed by Microsporum canis. Probably only about 10% of tinea capitis is due to the Microsporum species, and that's the one that's generally obtained from cats, infected cats or dogs. The Trichophyton species, it's usually spread from another child or person. So the clinical features vary quite a bit between affected individuals. There are some patients that have very minimal findings, and there are even patients that are asymptomatic carriers where there's no signs on their exam that they have tinea capitis, yet they do have the organism and they spread it to other individuals. Many people just have mild flaking and more of a seborrheic dermatitis type appearance with kind of a dandruff type presentation. Some patients will have areas of redness. Some people will mount more of an inflammatory response and actually have papules or pustules. Some people will develop areas of hair loss. Some people mount a very brisk inflammatory response and will develop a carry-on, which is usually a pretty dramatic inflammatory plaque, like the boy in the photograph. With darker hair, when the hair breaks off and can give a black dot appearance, in many patients you can have lymphadenopathy as a clue, so enlarged lymph nodes of the occipital scalp or the neck area, and sometimes you can have itching, but I don't think that really helps you with diagnosis a whole lot. So here are some more examples. Patient here that has significant hair loss. If you look close, probably has somewhat of a black dot appearance with this darker hair. This is a baby, young baby that had tinea corporis on the neck and had areas of hair loss and scalp involvement consistent with tinea capitis. A lighter skinned child with light hair, you can see erythema and a well-defined area of alopecia. This is a more inflammatory response. We see redness, we see scaling, and you see hair loss or alopecia. This one was a little bit, I think, less typical. This is a youngster that used a lot of hair oil, so you can't really appreciate any scale. And if you just looked at this and saw these many areas of fairly smooth hair loss, you might think this child had alopecia areata instead of tinea capitis, but this was also tinea capitis. And then a child who has, again, hair loss, inflammatory plaque, not a lot of scale. And then the boy from the first picture, he's got an inflammatory plaque here. There's overlying crust. He's got inflammatory pustules within his scalp, and he also had significant lymphadenopathy. So for the boards, you definitely want to be familiar with the different presentations of tinea capitis. You want to know what a carry-on is. The treatment for carry-ons is somewhat controversial, so I don't know that they would ask you that in a controversial sort of way, but most people think the best treatment is just to treat with systemic antifungal therapy, but there are individuals who feel that using systemic steroids concomitantly for brief periods of time may help very much in controlling the inflammation and reduce the risk of scarring. And this is the boy, same boy again here from a little bit different angle, but you can see this very pronounced lymph node enlargement. I have seen kids where they didn't have a lot in their scalp, but they had really enlarged lymph nodes, and they'd actually been seen by the surgeon and taken for lymph node biopsies. So when you're seeing large lymph nodes of the posterior scalp, or the occipital scalp, or the posterior cervical chains, anterior cervical chains, you really want to think about and look for any signs of tinea capitis. This is what we want to avoid, obviously. This is a child who had very long-standing severe tinea capitis. This is how she presented to us, with very widespread hair loss and probably significant scarring from chronic carry-on formation. So we've talked about the clinical features. Diagnosis is really based on clinical features, followed by supportive culture or potassium hydroxide preparation if you have that set up in your clinic and you're skilled at doing those. A fungal culture will usually use Sabarods or mycocell media. The DTM media that some pediatricians have in their offices is a decent screen, but there's a fair number of false positives, and you're also not able to identify the causative organism. Why bother culturing? Well, I think sometimes the diagnosis is not so clear-cut. If you have a patient with eczema and a scaly scalp, it's really hard to distinguish between secondarily infected eczema and a secondary tinea capitis. It's very helpful if you know what the organism is in choosing your medications. I do a lot of cultures when I'm trying to confirm that the condition has resolved and there's no evidence of fungus still, especially in kids who've had more chronic or recurrent courses. And then if you have a kiddo who keeps getting it, you might consider doing cultures of siblings to see if there's any asymptomatic carriers in the home. For the board exams, you definitely want to know that you cannot clear tinea capitis with topical therapy, and you probably all know that, but that's something that they tend to ask every year. You want to use systemic antifungal therapy, and there's several options available now. The gold standard and the oldest therapy has been griseofulvin, and many of us still use a lot of griseofulvin to treat tinea capitis, but we can now use fluconazole, itraconazole, terbinafine. Terbinafine has been recently approved for children for tinea capitis. So anyway, we have some other options now, and it just really depends on the individual patient and what you have available to you. But again, no topical therapy alone is not adequate. I'm going to not go into great detail on the different antifungals because all of this is in your handout and you can read about it, but there's a couple points that I'll make. With griseofulvin, You want to make sure that it's given with a fatty food that enhances the absorption of it. And there are two different forms, the ultra microsize where you have almost complete absorption and can use lower doses, and then the microsize where you have less absorption, so it requires higher doses. For the microsize, we typically use somewhere around 20 milligrams per kilogram per day, again, given with fatty food, and usually for approximately 6 to 8 weeks. Another content specification is that you do not need to get lab work if using griseofulvin to treat tinea capitis if you have an otherwise healthy child. And this is, again, more on dosing, around 20 per kilo for microsize. You can probably go down a little, and most people for ultra microsize will use somewhere around 10 milligrams per kilogram. So we've talked about tinea capitis. I just want to spend a few more minutes talking about alopecia. Alopecia is just the medical term that means hair loss. If you say someone has alopecia, you're not giving them a diagnosis. I have a lot of patients that come in and said, oh, I was diagnosed with alopecia. So alopecia can be any of these things that we're going to talk about: tinea capitis, alopecia areata, telogen effluvium, traction alopecia, or trichotillomania. And those are going to be the most common causes of hair loss in children. So here we see an example. This is a very typical example of alopecia areata. And the things that are characteristic of this patient are there are smooth, well-defined areas of total hair loss. But you don't see redness on the skin. You don't see scaling. You're not going to see an inflammatory response usually. They're just very smooth patches of alopecia. They're often oval or round in shape. Generally not associated with any other symptoms. You can sometimes see exclamation points, and I believe I have a picture of some exclamation point hairs that can be helpful in some patients. You want to look at their nails. Many of these patients that have alopecia areata will have subtle nail pits, and that can be a really helpful clinical clue. And alopecia areata is a big clinical spectrum. You can have patients that have one very small patch of hair loss that then regrows very quickly, or you can have the patient that loses hair not only on the scalp, but actually loses brows, lashes, even body hair. Now, the term alopecia areata totalis means complete loss of the scalp hair. If you have loss of the scalp hair plus eyebrows, plus lashes, and body hair, then that's referred to as alopecia areata universalis. This is a very unpredictable condition. It's non-scarring. There's often a positive family history, and there's some genetic studies that suggest there are certain genes that may play a role in this condition. The condition is often an intermittent condition where you have recurrent episodes of hair loss. And there is a slightly increased risk of having other associated autoimmune conditions, most commonly vitiligo or thyroid disease. The potential workup, if there's any question, if you see any inflammatory response, scaling, anything like that, you probably want to consider doing a fungal culture to make sure you're not dealing with an unusual case of tinea capitis, which you would obviously treat very differently and would have a very different prognosis. We sometimes will obtain thyroid studies. I wouldn't say we do that in every single patient, but I tend to get thyroid studies with very widespread alopecia areata, particularly young patients, very young onset, or certainly in children who have a very strong family history of thyroid disease, or if the child has any symptoms or signs of thyroid disease on exam or history. Treatment of alopecia. Diagnosis is easier than treatment. Treatment is very challenging, and many of these patients don't respond particularly well to treatment. But first-line therapy is usually a high-potency topical steroid, and for older kids, we sometimes will use intralesional steroids. For more recalcitrant cases, sometimes we'll use contact sensitization to try to induce an immune response, and occasionally topical anthralin. So here are a few more examples. You can see, again, this very smooth area of hair loss here, no redness, no scaling, no obvious inflammation. This just happens to be in the same area. This is not particularly a common area. You can see this anywhere on the scalp, but again, similar appearance. This child not only has hair loss, but has loss of this lateral brow here and probably has some eyelash loss as well. This is a child who has significant eyelash loss here. Now, if the child just presented with these eyelashes here, you'd also want to think about the possibility of trichotillomania or plucking or pulling the eyelashes. And we can certainly see that of the eyelashes or the eyebrows. This is a child who essentially has alopecia areata totalis, where she has complete hair loss. You can see a little fuzz coming in here, but she really doesn't have any terminal hair growth on her scalp. And these are some of the nail changes. You can see just very fine pits in the nails, or sometimes you'll see more generalized rough appearance of the nails, what used to be called 10-nail dystrophy or 20-nail dystrophy, where you had dystrophic nails on usually all nails, can be seen in the setting of alopecia areata. This is more typical, what you'll see, these fine linear pits here, like in this individual. Okay. Telogen effluvium is another very common condition. This is another non-scarring form of hair loss. Patients usually present with a thinning of their scalp. They don't tend to have bald patches, but just more diffuse thinning. And this is an event that usually follows some sort of physical trauma. The most common cause is pregnancy. So women will start shedding and losing their hair usually about 3 to 4 months after having their baby. We can see it in kids after severe illnesses where they've had prolonged fever, sometimes after surgery and anesthetic. It's usually a physical stress rather than an emotional stress. And the diagnosis is usually a clinical one made on the history as well as the examination. And there's not really any treatment that we can render for this. It's primarily providing reassurance and monitoring that the hair regrows as expected. So this is a hard one to photograph because you may not even appreciate that the hair is thin, but the child or the family may be able to show you old pictures, or if you follow that child for a while, then maybe you will see that difference. But this child has quite a bit of thinning throughout the scalp. Another very common cause of alopecia in children is traction alopecia. This is more common in African American patients, particularly if the child has been wearing a style that causes a lot of tension on the hair shaft, so very tight ponytails, tight, particularly small braids, and especially if they're doing those styles and then wearing heavy hair ornaments as well. Sometimes you won't see any other changes. You'll just see thinning of the hair in the areas where the tension has been, but sometimes you will see some inflammatory papules or pustules in my experience. The treatment is just very gentle styling of the hair, trying to minimize the tension on the hair, stop discontinuation of using any heavy hair ornaments, so just very gentle care. And this is an example here. You can see the thinning throughout the lateral hairline here. Another reasonably common cause of hair loss in children is trichotillomania, and this refers to hair pulling or hair twisting, causing the hair to fall out or break off. I think the biggest clues for this diagnosis are when you see hair loss in very strange patterns. So this is a very unusual pattern to see hair loss. You have this angular pattern here, almost triangular shaped here, and then when you look closely at the affected scalp, you can see that within small areas you have hairs of varying lengths. So you wouldn't expect to see whisker length hairs and 1 centimeter length hairs within a given area if it's a more physiologic cause of hair loss. You would expect the hairs to be in a similar stage of growth. So unfortunately, this is something we see periodically. It can involve scalp hair, eyebrows, eyelashes. Here we see a girl has that kind of irregular appearance of the eyebrows that you'll often see with trichotillomania. And you can see this at any age. There seems to be a better prognosis in the younger children that are affected. The older children, there tends to be a little bit higher association with underlying psychological or psychiatric disease. And treatment is usually based on behavioral modification. We usually work closely with our psychologists in that regard, and sometimes medical therapy is necessary as well. Okay. Got 3 more cases. The next one is a 1-week-old that presents to your office with a 2-day history of large pustules on the lower abdomen and the diaper area. The child is otherwise doing well with no reported systemic symptoms. The pregnancy and delivery are unremarkable. What do you think the child has? Remember, this child's 1 week old, and this is a 2-day history. Okay, so these lesions were noted at 5 days of age. Okay, so you see some pustules, you see some erosions with a little Colorado scale. What do you think this child has? Do you think he has transient neonatal pustular melanosis, neonatal herpes simplex virus, bullous impetigo, candidiasis, or epidermolysis bullosa? Okay, you're all going to get number 10, I promise. This one, okay, so most of you put, there's a close call here between bullous impetigo and transient neonatal pustular melanosis. I was trying to give you a clue by saying that it didn't appear until 5 days of age, so that was the most helpful thing in your history. If that had been present at birth with the pustules, then most likely this would have been pustular melanosis. But by 5 days of age, you don't generally have pustules, and so that can be very helpful in distinguishing between pustular melanosis and bullous impetigo, which is the correct answer here. I'm going to show you some examples of herpes simplex virus. These usually present with vesicles, crusted lesions, or erosion, so have a slightly different clinical appearance, but can occasionally present with pustules. So it's something you want to have in your differential diagnosis, and I think it's something you want to prove the child does not have. And then candidiasis is usually, if you're going to have pustules, you usually have lots of small papules and small pustules rather than these larger, more discrete lesions, and then the background skin looking pretty clear, as the case in this patient. And then epidermolysis bullosa is usually, those patients are going to have large bullae, most commonly involving hands, feet. It really, that's a huge clinical spectrum, so it would depend on what type it is, but would usually be in more trauma-prone areas of skin. And not usually pustules, they're going to be more bullae, vesicles or bullae. Okay, so that was your diagnosis. You know the right answer, so that's probably going to be a little bit confusing on this question. So let's pretend you don't know the answer. You don't know what this kid has. He's presenting to you. You see the pustules. The differential that we talked about is what's in your mind. Then what are you going to do to figure out what the kiddo has? Are you going to do a Zank smear in a viral culture? Are you going to do a gram stain in a bacterial culture? Are you going to do a potassium hydroxide stain and fungal culture, a skin biopsy, or are you going to do a combination of A, B, and C? I hope that was a helpful hint there. Okay. That's what I thought you'd put, but I think because we talked about what that child had, it was a little bit misleading. So you have a newborn come in, and they have vesicles or pustules like that, and you're thinking about what kind of skin infection could this be. You're probably going to want to do more than just the bacterial culture and the gram stain, and you want to make sure that it's not neonatal herpes. You definitely don't want to miss neonatal herpes. If you haven't seen a lot of candidiasis, you may want to make yourself feel more confident and rule out that possibility as well. So I think if you don't see a lot of pustular eruptions in young babies, the best thing is to screen for all 3 of these things so you don't miss anything. If the question is, what's the best way to diagnose bullous impetigo, then definitely a bacterial culture and a gram stain. So I'm sorry if that was confusing, but when you don't know what the kid has, you want to think about viral cultures, bacterial cultures, and fungal cultures. Okay, so that was the answer, and the patient does have bullous impetigo. So what is bullous impetigo? Well, this is a bacterial infection due to Staphylococcus aureus, and occasionally these days we can see bullous impetigo secondary to methicillin-resistant Staph aureus. In young infants, the area that you saw in that baby was the most typical area to be involved, the lower abdomen and the diaper area. If you do a gram stain, you should see gram-positive cocci in clusters, and if you do a bacterial culture, you should be able to grow out the Staphylococcus. Usually this requires systemic antibiotics in young infants where you're going to be a little bit more aggressive. And remember that this is due to toxin mediation, and this is a localized form of staphylococcal scalded skin syndrome. So this is going to be your typical example in a young infant. You're going to see pustules here. Remember, these are subcorneal pustules, so they rupture quite easily. And once they rupture, you'll see a shallow erosion with a little collarette of scale around it, like you see over here. This is a much more dramatic example. This also is bullous impetigo, but these are much, much larger lesions. So you see a large, flaccid bullae here filled with purulent fluid. And then here you can see this ruptured lesion. So the same thing, but more dramatic with this collarette of scale. This is after a week of treatment, so this is a very superficial process. These kids shouldn't have any permanent scarring or discoloration because it's subcorneal. Now, talking the difference between transient neonatal pustulomelanosis. Pustulomelanosis is a fairly uncommon condition. I really haven't seen all that much of it since I've been in practice. It's more common in African American infants, and there are 3 stages of skin lesions that you may see. The first stage are the scattered subcorneal pustules, and those are usually present at birth, rupture very quickly because they're subcorneal, often in that first bath of the baby. So that's why that was in pustulomelanosis, because by 5 days, those pustules are going to be long gone. If you see pustules after a few days of age, I think you really want to be thinking about the infectious causes. The second stage after the pustule, once that pustule breaks, you're going to see a superficial erosion of collarette of scale, very similar to what you see with bullous impetigo. And then the third stage is probably the most characteristic and the thing you're going to be most likely to see, and that's the hyperpigmented macule that can persist for several months. If you do a right stain, which is basically just scraping the lesion and putting the fluid on a slide, you will see lots of neutrophils, but you won't see bacteria when you have transient neonatal pustular melanosis. So that's how you could help. If you had the baby, you could do the gram stain, do the bacterial culture, and if there's no bacteria visible, it's very unlikely that it's going to be bullous impetigo. Okay, so this is showing these hyperpigmented macules that you will see in that third stage, and these lesions can last for several weeks and sometimes even longer. Okay. Other neonatal skin infections that you want to think about, we talked briefly about congenital candidiasis. This is generally a more widespread eruption where you can have either pustules or papules, and sometimes you will see some desquamation of the skin. We're going to talk a little bit, I'm going to show you some examples of herpes simplex virus, and we won't be going into congenital infections much in my talk. So you want to remember that for neonatal herpes simplex virus, the neonates that are going to be at greatest risk are going to be those babies whose mother developed a primary infection with herpes simplex virus during pregnancy. And you also want to keep in mind that neonatal herpes can be divided into 3 categories. The first one is skin, eye, and mucous membrane, and that's usually the least severe. The second is central nervous system involvement, and the third is when you have disseminated infection. So what do you see on exam? What are your tips to this condition? Well, if you're lucky, you'll see grouped 2 to 4 millimeter vesicles on an erythematous vase. That's the classic appearance. They usually start as vesicles and evolve into pustules. That's why I'm saying that when you have pustules, you still want to keep herpes simplex virus in your differential because you do not want to miss that. Now, they tend to be a little bit more clustered than what I showed you in bullous impetigo. But remember, with HSV, only about 1/3 to 1/2 of these babies are going to have the classic presentation with vesicles. They're more likely to appear with erosions, crusted lesions, and they may have other nonspecific associated systemic symptoms such as lethargy, poor feeding, fever, irritability. So here are a few examples. These are fairly characteristic examples, I think. You've got clustered vesicles here on the back of this child. I don't think this case is quite so obvious. You see more of the erosions. They look almost like annular lesions here on the face. So that one's certainly a little trickier. We've got some coalescing lesions here, more of the erosive stage that you're seeing. You can still see some fresh vesicular pustular lesions. These look almost more like pustules to me. You can see some areas here that have scabbing. The face and the scalp are fairly common areas to see this. This is a little more classic. You've got grouped vesicles on an erythematous base. This is very atypical. This actually ended up being neonatal herpes as well. I had no idea what this was when I first saw this patient, so I did cultures for everything, and lo and behold, this baby grew out herpes simplex virus. So occasionally you can see larger ulcerations. So again, if you're thinking about it, you want to do the studies to prove that this child does or does not have HSV. That includes a viral culture, depending on what your lab, what type of test they have. Some people can do fluorescent antibody assays or the DIF study. If you're experienced with doing Zank smears, that can be a helpful diagnostic tool, but it's certainly not 100% accurate. But it can be helpful with experience, someone who's experienced at obtaining them and reading them. And then, of course, a thorough systemic workup. And I'm sure you've gone over it with ID talks, but remember that you want to use high-dose acyclovir for neonatal herpes. One other example, again, I think these look more like pustules than vesicles, maybe a combination there. And you've got some crusting lesions, but that clustered appearance is very typical of HSV. Now, there are many other conditions that are non-infectious that can present with vesicles and pustules. So I'd be familiar with what some of those things are. We're going to go through a few of them. Some of these are very, very unusual. I wouldn't expect them ever to ask you about bullous mastocytosis. I doubt they would ask about incontinentia pigmenti or epidermolysis bullosa. But you want to be familiar, I think, with the more common newborn rashes, the benign ones. And we're going to go over a few of those. And then some of the infectious things we've talked about HSV and staph, a little bit about candidiasis. We've talked about scabies. But again, there are several other infectious conditions to think about. And then we've already talked a little bit about how you might reach a diagnosis by doing different stains, Gram stain, KOH stain, Wright stain, and then doing different cultures. And if you still don't have a diagnosis, certainly a skin biopsy can be helpful, but that's not something we have to do, and I would say the majority of children we see. So I would be familiar with some of the common transient skin eruptions. Here are a few of them. I'm going to go through some of these pictures. So here are two examples of milia. These are usually 1 to 2 millimeter white or cream-colored papules, and they're just very tiny inclusion cysts. This child has some milia on the nose here. These usually resolve spontaneously. This child also has some sebaceous hyperplasia on the nose, which is very common in newborns. And here's another example of this sebaceous hyperplasia, again, due to maternal hormones. Neonatal acne is very common. We define neonatal acne as being acne that occurs in the first month of life. This is probably not really acne. If you see in this picture here, these patients have monomorphic pustules. They don't tend to have comedones. So it's probably a misnomer. Most people think of this as being a hypersensitivity reaction to Malassezia furfur. So again, neonatal acne, first month of life, usually just pustules on the face. Infantile acne, on the other hand, usually presents after 2 to 3 months of age. It's due to androgenic stimulation of sebaceous glands, and in those patients, they tend to have a combination of comedonal lesions as well as inflammatory lesions. It is self-limited as well, usually resolving by a year of age. However, because it lasts longer and occasionally can leave scarring, you may be more inclined to treat infantile acne. Here's an example of infantile acne. You can see some large inflammatory papules, and because this child actually has nodules, you would be a little bit worried about this forming scars. And then if you look closely, you can see some open and closed comedones in this child. This is an example of miliaria crystallina, so very, very fine superficial vesicles here. If you run your hand over these, they rupture very, very easily. Miliaria rubra, people refer to this as heat rash. Due to sweat trapping, they can present with either diffuse, small erythematous papules, usually 1 millimeter or less, and sometimes very fine pustules. When you see this presentation, I think you want to think about cutaneous candidiasis as well, and that would be someone I would do a potassium hydroxide and fungal culture on to make sure I wasn't missing that. This is another patient with miliary. This is the same patient with miliary rubra that I just showed you on the abdomen. So very small pustules and erythematous papules. Erythema toxicum, very common in term infants, not typically seen in preterm infants. You tend to see erythematous patches or plaques that are studded with small vesicles or pustules, similar to this baby right here. If you do a right stain, if you get some of the contents out of the vesicle or the pustule and look at it under the microscope, you tend to see eosinophils, and that's virtually diagnostic of erythema toxicum. Here's another example that I think you can see those overlying vesicles and pustules a little bit better, again, overlying this blotchy erythema. So this slide just shows you sort of a summary, and this is in your handout, a summary of what you would find if you did a gram stain or a right stain and scraped open and got some contents, examined it on a slide. So with miliary rubra or heat rash, you're going to see lots of PMNs, neutrophils, but not bacteria. So you're going to see very similar things with miliary rubra as you will with pustular melanosis. With erythema toxicum, you're going to see mainly eosinophils. You might see some PMNs. You're not going to see bacteria. Pustular melanosis, again, neutrophils, no bacteria. And bullous impetigo, you're going to see neutrophils, and you're going to see gram-positive cocci in clusters. So scraping the lesions can be quite helpful. Okay, if you're all feeling like this, I can understand. So we'll keep going on. We've got 2 more cases, and the last one's super short. Okay, case 9. An adolescent female presents with a 1-week history of scattered targetoid lesions on the palms, soles, and lips. The patient is otherwise asymptomatic but had mild fever and malaise correlating with the onset of the skin lesions. What do you think the patient has? So 1-week history of these scattered targetoid lesions. So this is all the same patient. These are the targetoid lesions on the lip and on the hand and palms. Do you think this patient has secondary syphilis, hand, foot, and mouth, Stevens-Johnson syndrome, Behçet's disease, or erythema multiforme minor? Yay. Okay, you guys, most of you got this one. This is erythema multiforme minor. So we'll talk a little bit about that. Okay, so with erythema multiforme, or also known as EM, you will see fixed targetoid lesions that generally involve the acral surfaces, hands, feet, sometimes arms and legs, elbows, knees occasionally. And then you generally don't have any mucous membrane involvement, or you may have one mucous membrane involvement, and it's usually not nearly as severe as what you would see with erythema multiforme major or Stevens-Johnson syndrome. This is a self-limited eruption. It usually resolves within 2 to 4 weeks. So if it doesn't resolve within a month, you really want to question your diagnosis. The very most common cause of erythema multiforme minor is herpes simplex virus, and that's one of the questions that you have at the end of your handout. In contrast, the most common infectious cause of erythema multiforme major is mycoplasma. Okay. Treatment of EM minor is generally symptomatic care if there's any pain or itching associated with it. It's generally advised not to use steroids, and it's actually thought that if you treat with steroids, it may increase the recurrences of this condition. Because it is frequently a hypersensitivity reaction to herpes simplex virus, and can be recurrent, sometimes you could consider treating with prophylactic acyclovir if you had a culture proved, if you knew this was related to HSV. The main thing that this is confused with, and I'm going to show you a few pictures, is annular urticaria. So this is another example. These are more examples of erythema multiforme, and you can see these targetoid lesions here. You've got 3 concentric zones of color change here. You've got the palmar distribution. This is an example of the oral herpetic lesion, which you generally will have the history of that occurring 1 to 2 weeks before the erythema multiforme. So you may not see it. You probably won't see it at the time of the erythema multiforme. This is another example. Again, you can see these multiple zones of color change here. The center is often a dusky or gray color. This is because there's necrosis of the keratinocytes. You can sometimes even see a central blister or central erosion. This is another example of erythema multiforme. And this is to be contrasted with acute urticaria, annular urticaria, where you can see you've got central clearing, but you don't have true target lesions, and you don't have that central duskiness or gray-purple appearance. If you're a better, go with the odds. It's much more likely your child's going to have urticaria than EM. EM is actually very uncommon in children. This is the same boy here, and this is just another example of acute urticaria here. And you can see the lesions vary in size, they're more generalized, they're varied in shape, and some of them are annular. Urticaria is very photogenic. You can see these lesions are bizarre shapes. They coalesce and have these polycyclic lesions. Sometimes when that happens, sometimes they do look like they have multiple concentric zones of color change. The very most helpful thing is watching how these lesions evolve. In urticaria, the lesion should migrate within 24 hours. So if you circle a lesion and it's in another place, if it's gone within 24 hours, that's not erythema multiforme, and that's much more consistent with urticaria. Remember that with erythema multiforme, the lesions are fixed lesions that stay for several days. Hives is very, very common. It occurs frequently in infancy and childhood. In my experience, it's much more dramatic and disconcerting in those young infants and toddlers that tend to be more symptomatic and usually have much more dramatic appearance. It's referred to as acute urticaria if it's less than 6 weeks duration, and chronic if it's more than 6 weeks. This is an older child with urticaria. This is a very young child with urticaria. This is a 3-week-old. You can see swelling of the feet, which is very common. You'll often have angioedema or swelling of the hands and the feet, sometimes the eyes, sometimes the mouth. Sometimes you'll have annular or arcuate lesions here as well. And another example of these annular lesions where you have the central clearing. And again, you can see lesions of variable sizes here, some very small, some several centimeters. Coalescing lesions, again, tiny lesions, and then large coalescing lesions, more urticaria. This is also urticaria. Sometimes because you have extravasation of red blood cells, you'll have sort of a bruised appearance or purplish appearance of the skin. I think that's when people start thinking about erythema multiforme and worrying that might be what's going on. You can see a little bit of that here in this little boy. Okay. So I think when people see that, their concern is that these patients are going to evolve into Stevens-Johnson syndrome or toxic epidermal necrolysis, and that is usually not how Stevens-Johnson syndrome or TEN appears. Usually erythema multiforme virtually always just remains limited to the skin and doesn't have significant mucous membrane involvement. Stevens-Johnson syndrome usually appears very abruptly, and usually the mucous membrane involvement is the first sign, and the skin lesions follow over the next few days. This is an example of a young lady who had very mild Stevens-Johnson syndrome and also had signs of a drug hypersensitivity syndrome due to sulfa. So you can here see she's starting to get some lip involvement with some swelling and some discrete lesions there. She has diffuse facial involvement. She had some conjunctival injection as well. This is the full-blown end of that spectrum. This is severe Stevens-Johnson syndrome. And if you look here at these lesions, they have a different appearance than what we typically see with erythema multiforme. These are necrotic lesions. If you biopsy them, usually you're going to see full thickness epidermal necrosis, so necrosis of those keratinocytes. And that's why you have erosions and full thickness blisters like this. And then you will typically see these very dramatic mucous membrane changes, particularly the lips and the eyes. You can also have involvement of the genital mucosa or the perianal mucosa as well. And this is, considered a dermatologic as well as an ocular emergency. This is another patient. Again, you can see that this blister is a very tense blister. It's a full thickness lesion. You can see more blisters on his face. You can see the development of lesions on the lips, usually with very pronounced hemorrhagic crusting. This is a young lady who had toxic epidermal necrolysis, which is the severe end of the spectrum. You can again see this full thickness necrosis, these large, tense bullae here. And this young lady developed this from use of sulfa-containing eye drops for conjunctivitis. So it is absorbed systemically, so we have to think about that when we use those medications. Low risk, but a risk. This was a very sad case. This was a young man who developed drug hypersensitivity syndrome and developed multi-system organ dysfunction due to doxycycline therapy, and was later re-exposed to doxycycline because this diagnosis had not been made, and this child then developed full-blown toxic epidermal necrolysis. So you can see this widespread skin necrosis here on his thigh. This is a young man. Lamotrigine is another medication commonly responsible for Stevens-Johnson syndrome, or TEN. This is the same patient here. You can see these targetoid-like lesions diffusely on the skin. You can see areas of necrosis. You can see the involvement of the lips. So you certainly would want to be able to recognize a classic picture of Stevens-Johnson syndrome. And I think you'd also want to be familiar with what medications are most likely to cause Stevens-Johnson syndrome, and some generalities about the management. These patients are sick patients, obviously. They usually have fever. They have a lot of systemic symptoms. We talked a little bit about their skin findings. Typically, again, it starts with mucous membrane involvement, and then followed by blister formation, hemorrhage, or erosions, etc. They usually have at least 2 mucous membranes involved. And you want to get your ophthalmologist involved right away, because this can cause scarring of the eyes and significant permanent impairment. When we talk about Stevens-Johnson syndrome versus toxic epidermal necrolysis, that is a clinical spectrum, and it's based on how much body surface area has denuded skin. So if it's less than 10%, we refer to it as Stevens-Johnson syndrome. If it's more than 30%, then we call that toxic epidermal necrolysis. And if it's somewhere in between, we refer to that as Stevens-Johnson syndrome TEN overlap. These are the medications that most commonly cause Stevens-Johnson syndrome and TEN that I would familiarize yourself with. Sulfa antibiotics and the aromantic anticonvulsants, which would include phenytoin, phenobarbital, and carbamazepine. There's a high rate of cross-reactivity between those 3 medications. So if they're allergic to one aromatic anticonvulsant, you're best off avoiding all aromatic anticonvulsants. I mentioned lamotrigine. That's fairly common. Occasionally the penicillins or cephalosporins. Occasionally the doxycycline, minocycline, tetracycline antibiotics. Occasionally allopurinol. And then as far as infectious causes of EM major or Stevens-Johnson syndrome, which usually those terms are used synonymously, although there's some controversy about that, which we won't go into, Mycoplasma pneumonia is the infectious agent that you want to know, and that could definitely appear on your boards as well. So remember, HSV, EM minor, Mycoplasma, EM major, Stevens-Johnson syndrome. Okay, last case. This is a teenager that presents with a history of an approximately 3-centimeter red annular scaly plaque on the upper back, which was present for about 1 week before the patient developed multiple 0.5 to 1 centimeter scaly oval thin plaques scattered diffusely over the chest, abdomen, and back. The condition was associated with minimal pruritus but no systemic symptoms. So this is the original lesion here, and then the child developed multiple smaller lesions. Okay. Does this patient have guttate psoriasis, pityriasis rosea, pityriasis lichenoides, secondary syphilis, or contact dermatitis? Great. It's always nice to end on a positive note. So you guys all knew pityriasis rosea, and they tend to like this question still. So, okay. The main things I think are hard to differentiate between pityriasis rosea that can sometimes look a little bit similar is guttate psoriasis. And then in older patients and in patients that are sexually active, you certainly want to think about secondary syphilis, particularly if they have any involvement of their palms and soles. So I think you guys are all familiar with pityriasis rubra. I'm going to go rosea. Excuse me. I'm going to go ahead and okay. We saw this picture already. I'm going to show you a picture of guttate psoriasis. It doesn't usually start with a Herald patch, but it can quickly progress with multiple small scaly pink papules and plaques. and it's often triggered by a group A streptococcal infection of the oropharynx or the perianal area. And this is guttate psoriasis. So a little bit different appearance, but sometimes it can have some similarities. And this is just a close-up of the lesions. There's usually more scale involved with the guttate psoriasis. And there are lots of very, very small lesions like you see here. Okay, so the rest of the talk is trying to hit on the content specifications that I wasn't able to include in those cases. And I'm going to focus on the pictures because we have limited time here. And the text you guys can review from your handout. So a little bit on congenital melanocytic nevi. These are divided into small, medium, and large. Small is less than 1.5 centimeters. Large is greater than 20 centimeters. And this is based on what their predicted adult size is going to be. I think the things that are important to remember are the risk of melanoma is very, very low prior to puberty with small and medium-sized lesions, but it is more significant with lesions that are greater than 20 centimeters. The lifetime risk for these large or giant, some of them are giant, much larger than 20 centimeters, the lifetime risk is somewhere between 5 and 15%, and most literature would actually suggest between 5 and 10%. I think the other thing that's important to remember when you have these very large congenital melanocytic nevi is there is a significant risk even in the first decade of life, whereas with the small and medium ones, the risk is lower and it's a post-pubertal risk. So I think that affects the way we manage these patients. I think you also want to know that these large lesions, and this really is it's more common with large midline scalp and back lesions, but we've learned over the last few years it can actually occur with other locations as well. But some things you want to think about with these very large congenital melanocytic nevi are the possibility of neurocutaneous melanosis, melanoma, spinal cord abnormalities, Dandy-Walker syndrome, and of course the cosmetic ramifications. And I think you also want to remember that it's not just these giant lesions, but there is another subset of high-risk patients, and that is children who are born with 3 or more small or medium congenital melanocytic nevi. And I'm going to show you an example of that, but those patients always have, also have a risk of melanoma, Dandy-Walker, and neurocutaneous melanosis. So backing up a little bit, you want to be familiar with the ABCs and Ds of clinical monitoring of moles. And as a pediatrician, you certainly want to know what you want to be watching for these things, which briefly is asymmetry, border irregularity, color variation, diameter. That's a bit more controversial. Some people think that if it's greater than 6 millimeters, that's a higher risk lesion, but many congenital nevi are larger than that. I think the most important thing for children, which has been shown in several studies, is the evolution, so the presence of clinical changes. You also worry when there are associated symptoms of itching, bleeding, and certainly ulceration. So this is the lumbosacral area. This is a medium-sized congenital melanocytic nevus. This is one where you would think about underlying spinal cord abnormalities. And this is seen in this girl who was born with all of these pigmented nevi, and unfortunately this child did develop neurocutaneous melanosis and did die of it at 18 months of age. So you want to remember multiple congenital melanocytic nevi or very, very large lesions, and particularly those patients that are born with large nevi but also have satellite nevi. So this child is born with this giant, what some people refer to as a bathing trunk nevus. If you look here, has many, many other nevi. These are what we call satellite nevi. If you see a giant or large congenital melanocytic nevi and you see lots of these other smaller nevi with it, that is probably the biggest risk of both melanoma and neurocutaneous melanosis. So that's a higher risk category of patients. This is another patient. I think we'd all worry about this patient if we saw them in our office, but this child also developed neurocutaneous melanosis, and you can see giant lesion, lots of satellites. Okay. Let me just say one other thing. Neurocutaneous melanosis, if you're not familiar with it, basically what that is saying is that you have melanin deposition in the central nervous system, which can either be the brain or the spinal cord. And if you have a baby that's high risk for that, it's still somewhat controversial, but most of us do screen. Most pediatric dermatologists would recommend screening with an MRI of the head and the spine. But again, I think the most important thing is to know that babies with giant nevi and multiple satellites are going to be the high risk group for neurocutaneous melanosis. And neurocutaneous melanosis is probably far more common of a complication than melanoma actually is. So we're shifting gears dramatically here. This youngster here has a very characteristic skin eruption here. We see this erythematous lilac-colored eruption of her upper cheeks, the periorbital distribution, which you can't see so well. What is this? This is the heliotrope rash of dermatomyositis. This is another example here. And these are what? Gottron's papules. So typically, Gottron's papules occur over the knuckles, okay? But they're not always just on the knuckles. Sometimes they involve elbows and knees and other locations. Here we see them on the knuckles. They're a little more subtle in this dark-skinned child. He's got a little bit on the knees, not a lot, but a characteristic finding in dermatomyositis. The rheumatologists really like to look at the nail folds, and here we can see dilated capillary loops here around the nails. That's very helpful in diagnosing and also monitoring disease activity. And this is what we hate to see. This is calcinosis cutis. This is a late finding. This is seen in a minority of patients, but it's usually in poorly controlled, long-standing dermatomyositis, and something that's probably seen more commonly in children. So the main point I want to make here is that there is a difference between juvenile and adult dermatomyositis. There is no known association with malignancy in children with dermatomyositis, but about a 20% risk of occult malignancy in adults that are diagnosed with dermatomyositis. So an important distinction. So there are many characteristic skin features. We talked and demonstrated the heliotrope rash and the Gottron's papules and the calcinosis cutis, the nail fold changes, but there are other things as well: alopecia, Raynaud's, ulcerations. I have seen a few patients that have developed lipodystrophy and acanthosis nigricans, and similar to lupus, patients with dermatomyositis often have photosensitivity as well. Okay, we won't go through diagnostic criteria. We're going to shift gears. You guys know what this is, I'm sure. Acanthosis nigricans, so this very characteristic hyperpigmentation and thickening or velvety texture of the skin, usually of the neck, as well as the axilla. And this is pretty distinct, but occasionally it can be confused with a few other conditions: post-inflammatory hyperpigmentation, erythrasma, condition called confluent reticulated papillomatosis, lichen simplex chronicus. But again, usually pretty classic. Here are two more examples. The axilla, again, this darkening that you see and thickening. You can see sort of this ridged appearance, and you can see this area studded with little skin tags. This is most commonly due to underlying obesity and hyperinsulinemia. Pathogenesis is uncertain. It seems to be more common and certainly is more clinically visible, I think, in darker-skinned individuals, Native and African Americans, as well as Hispanics. Keep in mind that some patients will often have associated hyperandrogenism, so you want to screen for that with a good history as well and good physical examination. There are a few other things. Malignancy can present with acanthosis nigricans. So if you see a very thin person that presents and there's no obvious signs of hyperinsulinism on exam or on lab studies, you might want to think about the possibility, could this patient have underlying malignancy? That's much more common in adults for those of you who are doing med-peds. Certain medications can cause acanthosis nigricans. There are some genetic syndromes that can cause it, as well as the rheumatologic conditions listed there. Okay, another content specification is on papular urticaria. This is a chronic or recurrent papular eruption secondary to hypersensitivity to a variety of bites. It could be flea bites, it can be mosquitoes, bed bugs, mites. It's a pruritic eruption. These patients will usually get multiple urticarial papules that are frequently grouped or clustered, may have secondary infections, occasionally can be secondarily infected. And here are a couple examples of papular urticaria. And we usually treat this with antihistamines, topical steroids, that kind of thing. Obviously doing things to try to avoid bites and figuring out what the culprit is. Okay, you should know what a nevus sebaceous is. This is a hamartoma of the appendigeal structures involving the sebaceous and the african glands. seen in about 1 in 300 newborns. It's considered to be a type of an epidermal nevus. There tends to be no gender or racial predilection. This is a pretty classic one here, the salmon-colored plaque within the scalp. Again, it's congenital, and you usually have overlying alopecia or greatly reduced hair growth. This is another example. Sometimes they have a little bit of a yellowish pink color, more of a deep salmon color. They often, in my opinion, have a waxy texture to them. Your differential diagnosis is probably going to be most commonly aplasia cutis. I think that's probably the thing that looks most like it. Now, the thing you want to know is that these are usually very stable during childhood, but during adolescence, when the hormones are increasing, they can stimulate these lesions to become much thicker, and they can become more verrucous. And then in young adults and older adults, there's a very small risk of developing secondary tumors, which can be benign or malignant. Rarely they can develop basal cell carcinoma. So for that reason, we will sometimes recommend surgical excision. That's certainly not in all patients. It really depends on the size of the lesion and how amenable it is to surgical resection. This is an example of a nevus sebaceous in an adolescent, and you can see this lesion is becoming thicker and more verrucous in texture. Okay. This is a nodule. This is a congenital nodule on the lateral brow. Asymptomatic, it's firm. This is an example of a dermoid cyst. And I think the things you want to remember, treatment is excision. These do tend to enlarge over time. These are usually present at birth, although they may not become noticeable until they have grown somewhat in size. There is some risk of intracranial extension, primarily with midline lesions, nasal lesions, or when you see signs of a dimple or a sinus tract. And I'll show you an example of that. So here we see this little extruding hair here. That would be an example of a sinus tract, and this is also a midline nasal lesion. So this is a child you want to get an MRI scan, probably refer to neurosurgery or plastic surgery, but you're going to want to get very fine cuts there looking for intracranial communication. Okay. All right, I'm going to show you a few examples of tinea corporis and contrast that with granuloma annulare. Remember, tinea corporis is an epidermal process, so you'll tend to have scaling of the surface of the skin, where GA or granuloma annulare is a dermal process, so you should not have scaling on the surface of the skin, but they are both annular lesions. So tinea corporis, similar organisms as to tinea capitis, the trichophyton species Microsporum, occurs more with warm, moist conditions. Here's another example. It's nice when they're round and have a central clearing, but that's not always the case. Pretty typical on the left, a larger lesion. This is an atopic patient. The patient has atopic dermatitis and is using topical steroids frequently and moisturizers, so probably promoting the growth of the fungus in that child. And this would be more of a tinea incognito because you are masking some of the clinical features with topical steroid use. I think we'll skip ahead here. These are a couple examples, and this is just to show that not all ringworm is ring-shaped. Sometimes these lesions can be quite inflammatory. You can see them studded with pustules. Just like the scalp can have inflammatory responses, so can the skin. And in those situations, sometimes it's a little harder to diagnose. So your differential diagnosis of tinea corporis is usually going to be nummular eczema. That's probably the thing that's most commonly confused with tinea corporis. Psoriasis, granuloma annulare, which I'll show you in a minute. Pityriasis rosea before the rest of the eruption occurs. Occasionally contact dermatitis or secondary syphilis. This is a child that had very widespread tinea corporis. This was due to a little kitty in the house that he loved to hold on his chest and body. And then this just shows you, hopefully you can appreciate this epidermal change with this peripheral scale here and then this nice central clearing. And this is much easier to get a KOH on the skin, so that can be very helpful to do a potassium hydroxide stain. Here we can see these branching hyphae here, which help confirm your clinical diagnosis of tinea corporis, and then you could certainly do a fungal culture as well. And this is the child after 1 week of griseofulvin. We use systemic medication in this child because this eruption was so widespread. And typically we will use, I think you should be familiar when you would want to use systemic treatment. We've already talked about when there's hair follicle involvement such as in tinea capitis, if you have widespread lesion, if you have a recalcitrant case that's not responding to topical and you're certain that it is the right diagnosis. And also you want to think about it with immunocompromised hosts. Okay, so this is not tinea corporis, although it's frequently confused with tinea corporis. This is granuloma annulare. This is probably the most common place that we see granuloma annulare, which we call GA. This is usually a smooth dermal annular plaque, pink to lilac in color, often occurs on the dorsal feet or hands and sometimes on the shins. But you don't generally see any scaling. And if you feel it, there's much more substance to this than there is to tinea corporis. It's a benign condition. It's self-limited. We don't really know what causes it, but fortunately it does go away on its own. And it does have a very typical appearance under the microscope. So if there is any question about the diagnosis, a biopsy can be very helpful, but usually that's not necessary because it is so classic on exam. Here's another example. More examples, typical locations. You can have 1 lesion or multiple lesions. More widespread lesions on the shin of these individuals. Okay, now shifting gears. So now we're going to talk a little bit about diaper dermatitis. So these well-defined erythematous plaques here are examples of diaper psoriasis. And you want to think about that when you have very well-defined red plaques. These are 2 more examples of psoriasis. This one on the right has a secondary candidal infection. You can see these satellite papules and pustules. Okay, this one, I think, I looked through the hand. I think this one might actually be out of place for what we talked about. This is actually perianal dermatitis, and I think this picture is going to show up again a little bit later. So circumferential erythema around the anal area in brothers who both have perianal strep dermatitis. Okay, so this little baby has a stubborn diaper rash, won't go away, no improvement with antifungals, emollients, barriers, etc. So if you see this, and especially if you see it perioral, what are you worried about? Zinc deficiency, exactly. So this is acrodermatitis enteropathica or zinc deficiency. This is the same baby here, and this is how he presented. This was a breastfed baby about probably 3 months of age. I'll let you go through it, but I have not ever seen the inherited form. I think the type you want to be more worried about seeing is that which we see in breastfed babies, where for some reason they're not getting adequate secretion of the zinc in the maternal milk. You can sometimes see it in older patients that have conditions where they have malabsorption as well. Protein malnutrition can be very similar in appearance to zinc deficiency. This is a patient that had a food aversion and was malnourished, had protein malnutrition. And you can see, this is what people refer to as the flaky paint dermatosis here. So you can see this sort of desquamation here that's like paint peeling off. And it's very common in this diaper area, although it often can be more generalized than that. It can look very similar to cystic fibrosis. So I think the take-home point here, you may not be able to differentiate between zinc versus protein versus cystic fibrosis looking at these kids. They're not going to ask you things like that, I don't think. They might ask you the zinc one. But you want to be aware that nutritional deficiencies definitely can cause an exfoliative diaper dermatitis, and they can have quite a bit of overlap in their clinical features. And usually once you've replaced the nutritional deficiency, they have a very good response to that. So this is with a patient with cystic fibrosis after nutritional support. You know, this was within a couple weeks how much better it was. This is something you can also see with biotinidase deficiency. This was a baby that was diagnosed with holocarboxylate synthetase deficiency. And unfortunately, I didn't figure that out. This was diagnosed because the baby later presented with acidosis and was quite ill. And fortunately doing well now, but I certainly did not figure out that one after multiple workups. And this is another one you don't want to miss. And I'm going to show you a few examples because it really took me a while to pick up on how this looks. You have to see a lot of clinical examples. And I think this could appear on the boards as well. It's certainly something they want you to recognize. So I think the catchwords are going to be that you have a persistent diaper rash with a seborrheic type appearance, and they might mention crusted papules or hemorrhagic papules, something like that. You guys know what this is? Yeah, I've heard somebody say histiocytosis. So this is Langerhans cell histiocytosis. I think the big clues are these are very erosive lesions in some patients, sometimes even ulcerative here. This is a lot more serious than what you're going to see with seborrhea, where you just have some maceration. And you're not usually going to see these discrete crusted papules in seborrhea. So this really, to me, looks very, very different than seborrheic dermatitis, but it's always described as being in that seborrheic distribution. This is another example. So persistent erosive dermatitis, especially in the skin folds, the perianal area. This is all the same child here. So he had this fine papular eruption. You can see the diaper involvement here. You can see this fine papular eruption on the scalp here. So this child also had LCH, or Langerhans cell histiocytosis. This would be a good board exam picture. So this is the sort of thing they might say, chronic dermatitis of the scalp with crusted papules. The scalp is another common area to be involved. Okay, so those were just a few. They would show you classic pictures if they were going to show you that. Okay, this is another one. I don't know if this would appear or not, but I think this is an important one to recognize. This is a baby who's a few weeks of age that presents with annular lesions on the face and scalp with some predilection for the skin around the eyes. And this is an example of neonatal lupus. Neonatal lupus can cause cardiac disease or cutaneous manifestations. They're usually one or the other and not an overlap of those. They might ask on the boards, what is the #1 cause of congenital heart block, which happens to be neonatal lupus. Many of these patients will require pacemakers. And you want to remember that this is due to maternal passage of anti-Ro and anti-La antibodies transplacentally. Usually the skin manifestations will appear at birth or in the first 8 weeks of life. Because this is caused by placental transfer of maternal antibodies, it's a self-limited condition when it involves the skin. Unfortunately, the cardiac heart block is a permanent thing. So I'm going to show you a couple more examples. These patients usually have face and scalp involvement. They usually have a lot of periorbital involvement. Some people call this a mask-like appearance or raccoon eyes. And sometimes the lesions can be more annular, almost look like what you'd see in an older person with like discoid lupus. Sometimes you'll see erosions. This is another baby. These are just more examples of neonatal lupus. And you want to remember that less than half of the moms of babies with neonatal lupus will actually carry a diagnosis of rheumatologic disease. So the diagnosis is not only important for the baby, but probably more so for the mom and also for subsequent pregnancies, because that mom will then be at increased risk of having a subsequent pregnancy or baby with neonatal lupus. This is showing the self-limited nature. So this is the little baby there with these annular lesions again. And this is at just about 4 or 5 months of age, so they had already resolved completely without any kind of treatment. So I think the other important teaching point here is when you see a very young infant that has what looks like tinea corporis, you want to confirm that with a culture if possible, because tinea corporis occasionally can look like neonatal lupus. You usually have more scaling with tinea corporis, but sometimes it's a hard distinction. So I think especially if that baby, comes out and at birth has lesions like this, you want to be very skeptical of a diagnosis of tinea corporis and be thinking, could this baby possibly have neonatal lupus? This is another baby with neonatal lupus. This happens to be the prior baby's brother. So as I mentioned, subsequent pregnancies can be affected. So this is the same baby. You can see, again, this forehead and facial distribution, periorbital involvement, some annular lesions on the belly. And they both are doing great. So, and mom did not have a diagnosis but has systemic lupus. Okay, perianal dermatitis, more pictures of that due to strep. More examples, those brothers that you saw a few minutes ago. Keep in mind it can also involve the perineal area, the vaginal area, the penile area. These are all examples of perineal strep. The bright redness is certainly a clue, the distribution. There's often a lot of itching associated with it. And And then also keep in mind that young babies, especially those that get seborrhea, can get streptococcal intertrigo. So here we see a few examples of that. When it's particularly moist, macerated, if there's any odor or drainage, you want to think about secondary strep infections, which we see pretty commonly. Okay, we talked about molluscum already, so we'll just quickly go through the pictures. Skin color to pink papules, central umbilication, clustered here on the chin and neck. This is with the associated dermatitis, which we talked about earlier. Larger lesions, the body can develop an immune response, and so these lesions will often become red, swollen, infected appearing as the body is mounting an immune response. Usually the lesions resolve within 1 to 2 weeks after that inflammatory response. Okay, I'm not going to talk much about treatment. That's all in your handout. Just a few pictures of warts. I think you want to be familiar that they're caused by the human papillomavirus, some of the treatments that can be used in children. We don't want to be too aggressive. We worry when we see them in the genital area because of the risk of them being sexually transmitted, although the vast majority tend to be innocently acquired and are usually maternally transmitted. These are very extensive cases of genital warts, a little bit more limited there. And many of these will just resolve on their own, so you don't want to be overly aggressive in treating. I think you do worry more about sexual transmission when their kids are older, especially if they're 3 or older, but that 3-year is not a hard and fast rule by any means. All right, and then the other thing that seems to appear frequently on the content specification list is to know that roost dermatitis or poison ivy is not spread by the fluid that's contained in the blisters or the bullae, because remember, it's contact with the plant. So the lesions themselves are not contagious. And we finished at 5:30 on the dot, so I'm very pleased. Thanks for being such a good audience.